Okay, so I told you in the morning that for the HPV-associated invasive endocervical adenocarcinomas, what you look at scanning magnification is for mitotic figures and apoptotic bodies in the apical part of the cells. So whenever you detect these ones, you are going to have a usual type, right? But you have to go very fast. If you have troubles with identifying them, it means that it may be not a usual type. But when you see this kind of cases, and I'm going to show another case, it is going to be usual type. Now, I told you that most of the cases of usual type are P16 positive, and just to make sure what is P16 positive and what is P16 negative, we see that this is a P16 positive, right? For everybody, right? This also. All of this. There are a couple of cases in which the P16 is negative, right? I think this one. And then there are others in which they look like this, right? So this is not positive because it's patchy. Now, that one can be, because as I told you, the usual type can be sometimes P16 negative, but the HPV is going to be positive, right? So you can have a usual type, but with P16 negative, and then you have to go to the HPV testing. Endometrioid type is going to be HPV negative in all of the cases. Endometrioid type is not going to have luminal apoptosis and mitotic figures. Endometrioid type can be P16 positive if it's high grade, right? So the P16 doesn't have much. What has is the HPV. This is an ovarian mass, again. And let me show you the epithelium of these structures. And tell me what you think about it. So it is a stratified epithelium here, typical, and the light is not very good, but what you see here are atypical mitosis. So whenever you have, it's again a bilateral mass, and whenever you have this kind of cases in which you can easily detect, mitotic figures and apoptotic bodies, you have to think of cervix as well. I'm not saying that all of them come from the cervix, but you have to think of the cervix. And in this case, actually, I'm going to show you, this was a metastasis, I'm going to show you the primary tumor in the cervix. Looks like this. Alright, so again you have glands, more or less mucin. Then you go higher power, easily you can detect the mitotic figures all over the places, right? Substratified nuclei, elongated nuclei, and all the other characteristic criteria are easy. But then if you see these mitotic figures and apoptotic bodies around the lumina, this is usual type, right? This is HPV associated, and it's very similar to the one in the other. Now, I told you in the morning that there is a new entity which is called the invasive smile. So in 2000, the in situ smile was described. Anybody knows what the in situ smile lesion is? So SMILE is an abbreviation coming from stratified mucin producing intraepithelial lesion, right? It was thought to be an adenosquamous lesion until together with the markers and everything, we have realized that this is a glandular in situ lesion. And about 2-3 years ago, an invasive SMILE has been described in the literature, and it looks like this. So you have nests of cells that are invading. This is a C-type, no problem. And these nests have a very characteristic appearance. They have mucin, abundant mucin into the cytoplasm that is pushing the nuclei at the basal side of the cells. And they can have lumina as well. These nests, they can be associated with classic usual or classic mucinous, and sometimes they have something that we found very unusual, which is this kind of almost echoelicitic look like cells. Now the cells have a clear cytoplasm. Everything is P16 positive, 100%, and everything is HPV positive. So remember this kind of cases that probably in the past we called adenosquamous invasive carcinoma. Especially because in some areas, I'm going to see if I can find, some of them can have usual type of cancer here. They can have real glands as well, atypical glands. So this was probably called adenosquamous, and that's why we have included the adenosquamous at the beginning of the project, because we thought that some of them will turn out to be not adenosquamous, but something else, actually. Okay, do I have time for one more case, or I have to stop? Just, it's up to you. Thank you. I stop.
Very nice, interesting case, very nice slide quality. So it's a pleasure to introduce for you Dr. Asma Farouk, consultant histopathologist on health in field for next presentation.
Hello everyone, thank you for staying back to listen to me, and this is going to be a whistle-stop tour, as they say in Britain. So we're going to zip through a few entities. Please stop me if I go over time, and if I talk too fast, can someone please tell me to slow down a bit, okay? Thank you very much to the organizers for allowing me to speak here and for inviting me to this beautiful country. I'm loving every second of it. So, without further ado, pointer. Okay, so the first case is a 69-year-old lady with a history of ovarian carcinoma. They imaged her and they found a solid and cystic mass in her vulva. And before they took her off to surgery, they said, we're going to take this mass out and see what on earth is going on with her. This is what it looked like. So you can see lobules of mucinous glands and some duct-type structures here and there. In size, it was about 6 to 7 centimeters in diameter. This is a higher power view of it. You can see mucinous glands and you can see these variable sized cysts. This is just another view of it. You can see these mucinous jobbies over here. And this is the periphery of the lesion. You can see that it's not quite circumscribed. It's sitting next to these rather thick walled blood vessels. Well, we're not surprised because that's the vulva, so you can see some thick walled blood vessels there. And it's not encapsulated. Another view. This is inflammation. Over here, you can see that this epithelium is infiltrated by lymphocytes, neutrophils, plasma cells. And this is just to prove that I'm not making it all up. It is actually mucin because that's a PAS stain after diastase digestion. And here's the immunohistochemistry. So ER is negative, PR nuclei negative, but there is some positivity in the cytoplasm. Any takers for this one? Benign malignant, do you think? Alright, I think everyone's worn out. It's been a long and tiring day. Don't blame you. Okay? CEA, focally positive. K67, extremely low. So this is nodular hyperplasia of Bartholin's gland. You might wonder why on earth am I showing you this? It's because it's not uncommon, this condition, and in actual fact I think that it's underreported because people don't really think of it. This is the differential diagnosis of lesions in Bartholin's glands. The last three, the neoplasias, are really adenoma. The main differential is with an adenoma, and adenoma is vanishingly rare. I've never seen one in all these years that I've done gynae pathology. But they have been described, and I think there was a paper by Tavasoli which put out criteria for diagnosing adenoma of Bartholin's glands. And the difference is that those are very circumscribed lesions, and this is not circumscribed at all. And it's quite often associated with a dilated Bartholin duct cyst. And in fact, the next time you get one, if you have a look at the subjacent stroma, underneath the cyst, you're going to see dilated lobules. It's just one of those things. It's a lobular proliferation, no atypia, no mitosis, tends to be underreported. Does it matter if you miss it? Absolutely not. It's a benign condition. So why should we bother to look for it? It's because we can. And we're histopathologists and we know everything. So we'll just tell the clinician, yeah, that's Bartholin's lobular hyperplasia. Okay? Case number 2 is a 68-year-old woman. She's got postmenopausal bleeding, and this is what was in her uterus. So what you see here is a tumor which consists of sheets of small blue cells. This is another slide from this case, and here you can see some glands. Quite well differentiated glands. I mean, you can see that they're clearly glandular. This is another one. So on one side you can see these sheets of small blue cells, on the other side you can see some glands. Anyone got any ideas about what they think this might be? Carcinosarcoma, it could very well be carcinosarcoma. Any others? It could very well be the differentiated carcinoma. Okay, so everyone is actually listening. Thank you. So what are we going to do? Shall we do a P53? Well, I did anyway. So, this is a wild type P53. I haven't given you, you'll have to take my word for it. It looks completely null, but actually it wasn't. There was a few cells here and there. And here's the ER. Now you can see on one side of this section is the glandular bed, and on the other side of the section is the solid bed. Glands over here and the solid bed over there. So the glands are positive, the solid bits are negative. What else can we do? So carcinosarcoma is a very good differential diagnosis. Dedifferentiated carcinoma is also an excellent differential diagnosis. Anything else that it could be? Could it be a collision tumor? Because they're sitting next to each other. They're not mingling. They're not speaking to each other. It could be a collision tumor. So I did a host of immunohistochemistry on it, but this is what the final diagnosis was: dedifferentiated carcinoma. And what is this? It's a tumor that's composed of medium, now undifferentiated and dedifferentiated, I put them both together. The difference between undifferentiated and dedifferentiated is that undifferentiated has no gland formation at all. It's sheets of cells. And when you look at it down the microscope, it could be anything. It could be a lymphoma, it could be a carcinoma, it could be anything. It could be a sarcoma, and carcinosarcoma is very much there in the differential. So, if you see glands, then it becomes a dedifferentiated carcinoma, and interestingly, the glandular element is usually a low-grade endometrioid carcinoma. And the important thing here is that these tumors are associated with Lynch syndrome, mismatch repair gene abnormalities. And that's kind of important to know, especially because from the woman's point of view and from her family point of view, it's important to know. In my department, we almost do a reflex immunohistochemistry for mismatch repair gene. If the woman is under the age of 50, if she has a lower uterine segment tumor, if she has undifferentiated carcinoma, if she has a variant clear cell carcinoma, we always do immunohistochemistry and inform the clinician of the result. These particular tumors often occur in the lower uterine segment and have a very prominent lymphocytic infiltrate often. And that's going to give you your first clue that this could very well be differentiated carcinoma. And since ovarian clear cell carcinoma is also associated with Lynch syndrome, they can be synchronous tumors in the endometrium and the ovary. Immunohistochemistry is often very unrewarding. In fact, it can often be completely negative for cytokeratin. In my experience, I found that epithelial membrane antigen is often better than cytokeratin. And even that, you're not going to get every single cell staining up. It's just going to be, scattered around here and there. ERPR negative, and in this case, this was the mismatch repair gene profile. So PMS2 and MLH1 were both completely negative. And she did have a germline mutation. Case 3 is a woman with blood-stained vaginal discharge and a friable hemorrhagic polyp in her upper vagina. And the surgeon rang me and said, can you process this urgently, because it was just before Christmas or something, because we think she's got cancer. So this is what it looked like. You can see that the stroma is rather blue, and then you can see it's kind of polypoid. Here you can see again, bluish stroma. And here's the epithelium. So notice this epithelial lining, little discohesive on the top. Some of the cells are falling off. Here are the glands. So you can see these glands within the stroma. They look a tiny bit blue as well. I'm going to give you a higher power. Here they are again, a little bit haphazard. Would you say they're haphazard? They're not evenly distributed, are they? Higher power. Again, now we see that the blueness of the stroma is due to lymphocytes and plasma cells floating around. But again, you're seeing this kind of thing on the surface. So there is some dyscohesion. Again here to show you the epithelium lining this polyp, some cells falling off on the top. Higher magnification, I've put a little red star next to some mitotic figures. And you can see at least 1, 2, and I think over here, another mitotic figure. So this is obviously mitotically active, and next to the star there seems to be a little bit of nuclear enlargement as well, so rather heterogeneous nuclei. Again here, just to show you the epithelium, another star next to this mitosis. Any thoughts? Anyone got any thoughts on this one? Okay, this is what it turned out to be. And here's the WT1. I was very mean, I didn't show you the WT1 beforehand, but here it is. And this is what one of my favorite fictional characters said: data, data, data. Surgeons do not give us clinical information. If they had told me that this patient had a hysterectomy 2 years ago, I would have been thinking about prolapsed fallopian tube straight up, because that is the usual history. The patients had a hysterectomy, then they present with some funny bleeding thing in their vagina or some nodule, and you take it out and this is what you see. And because it's inflamed, it's got mitotic figures, it's got reactive atypia, and it all looks very funny. And tubal epithelium in any case is quite heterogeneous. Even benign tubal epithelium has got all, at least 3 different types of cells in it. So they all look different from each other. So there you are. Rarely it can occur in other conditions like, pelvic endometriosis and things like that. And the most important thing is to bear it in mind. Why should we bear it in mind? Because in the vagina, there's a limited number of conditions which can cause adenocarcinoma. And it's kind of rare in the vagina. I'm not saying it doesn't occur, but it is kind of rare. So we must bear it in mind and remember that it can look atypical. And of course, history is pretty vital. So there you are. So what about adenocarcinomas in the vagina? They can be primary or secondary. The primary ones can be DES associated, or they can be sporadic. I mean, these days, DES is used, diethylstilbestrol, isn't really used anymore. So most of the cases are sporadic. And the secondaries, which are commoner when you see an adenocarcinoma in the vagina, a secondary must always be considered, and it could be a female genital tract from further up, or it could be extragenital. And this is just a list of differential diagnoses. I don't think I have the time to go through all of them, but I'll show you some of the interesting ones. So vaginal endometriosis, of course. This is spread from cervical cancer, and in the inset you can see that it's strongly positive for P16. This is metastasis from the ovary. There was a clear cell carcinoma in the ovary, and beware P16 in these cases, because if you just do a P16 on this and you don't think about it, you're going to think it's HPV related, which it isn't, because high-grade ovarian serous carcinoma is often P16 positive. This is vaginal adenosis. This woman did not have any history of DES exposure, and you can see that the glands are all variable in size. Some of them have squamous metaplasia. This is prostatic tissue in the vagina. These pictures were lent to me by Professor McLuggett, who's written a paper on this, and you can see this not only in the vagina, you can also see it in the cervix, and it shouldn't be mistaken for neoplasia. And PSA is positive, and the tubulosquamous vaginal polyp, which can also arise, which usually arises also from prostatic type tissue. Last case. How am I doing for time?
Okay, for one more case.
Okay, so this is going to go really fast. Okay, so 54-year-old woman presented in great distress to her GP because she was getting very hairy and she wasn't happy about it at all. So off he sends her, and she has all sorts of investigations, and she turns out to have ovarian masses with a firm tan cut surface. Here's the ovarian mass. You can see it looks like there's something growing in there. This is what's growing in there. So you can see these spindly cells, a little bit whorled. Then you can see these little round things, some ductular/glandular structures. Here they are again on one side of this section. You can see these, which are forming some sort of glands. Then in the background there's that spindly stroma, and then you have these cords of cells with quite eosinophilic cytoplasm. Another view, again, cords of cells and some gland-like structures, and this spindly stroma in the background. Again here, some solid little islands and cords, and there's the inhibin stain. So what does everyone think this is? Sorry? Sex cord stromal tumor. I am a very bad person, can I just say, because I have only given you half the story. That's what I thought it would be. Okay? It's only when I took extra blocks from this. Now we see this thing. So on one side the stroma looks paler, on the other side it looks darker. And now we're seeing some glands which appear to have vacuoles in them. And here's the CK20. And here's the CK20. 20. 20. 20. 20. 20.